Today we're diving into the fascinating world of haptic technology, using wearable patches that harness touch and feel sensations to deliver potential health benefits. We know that the skin is a powerful organ. Every inch has over 1,000 nerve endings that relay messages to our peripheral and central nervous systems. These nerve endings convert mechanical energy, like touch or haptics, into neural signals, which the brain deciphers to promote sensory awareness and stimulate physiological changes. Haptic wearables, including patches, have been shown to enhance rehabilitation in stroke victims, improve prosthetic devices for amputees, and amplify sensory training for vision and hearing impaired patients. The wearables we will be discussing today, vibrotactile trigger technology, or VTT, have shown positive outcomes for patients with pain, stress or anxiety, and sleep disturbance, and have even been demonstrated to improve athletic performance. We hope to share with you the emerging cutting-edge science and data on the ground floor of this technology. I'm Dr. Jeff Gooden, and I will be your host today. My areas of expertise include topical analgesic therapies, and I have authored numerous publications on areas related to pain management. I have also co-authored studies on the vibrohaptic technologies that will be the focus of our discussion today. Dr. Anna Toker is a distinguished, award-winning, board-certified colorectal surgeon with over 20 years of experience in the Dallas area. Renowned for her ability to translate complex medical concepts into everyday language, Dr. Toker attracts patients from across the country seeking her surgical expertise and nutritional guidance. She is also a researcher and has been a principal investigator on vibrotactile haptic clinical trials. Dr. Marc H is a dual board-certified physician in family and sports medicine, having earned the degree of Fellow of the American Academy of Family Practice. He currently serves as Director of Athletic Medicine and Head Team Physician for the University of Arizona, as well as the Medical Director for USA Rugby. He was an assistant professor at the University of Pittsburgh and Duke University Medical Centers. He was also Associate Team Physician for the NHL's Carolina Hurricanes, Head Team Physician at Georgia State and Robert Morris Universities. He is also a researcher and has been a principal investigator on vibrotactile haptic clinical trials. Peter Hurwitz has held senior leadership and management roles for more than 35 years in the medical communications, scientific research, and healthcare fields. He is president of Clarity Science, an internationally recognized clinical research organization, or CRO, and a peer reviewer for several scientific journals. He has co-authored dozens of peer-reviewed scientific articles relating to pain management, diabetes, allergy, neuroscience, and artificial intelligence in medicine. For the past several years, Peter has worked with White House administrations and Congress on healthcare policy to address the opioid crisis. Peter leads the CRO that has administered at least 6 clinical trials to date using vibrohaptic patch technologies. The prevalence of pain and pain-related diseases are so vast that they are the leading causes of disability and disease burden across the globe. Over 100 million people are estimated to live with chronic or recurrent pain in the United States, and 50 to 7 million people are estimated to have sleep disturbance that interferes with their daily activities. These conditions are amongst the most common reasons that patients consult primary care clinicians. The haptic technology product that we studied and are here to discuss today is called SuperPatch. Anna, can you tell us a little bit about SuperPatch?
Sure. This is a very fascinating technology, and I think it's going to represent a paradigm shift in the world of medicine because it utilizes physical therapy instead of prescriptive medications to affect an outcome. These devices don't have any medicine on them. There's no contraindication to using them. They're these 2-inch by 2-inch little Band-Aid looking squares, and embedded in the glue of these adhesive patches is a texture. When that texture touches your skin, it sends a specific signal along the nerves of the skin to your brain to normalize a neurologic pathway in your brain. So each of these patches has a different signal, which means it affects a different part of the brain. And much like a QR code might direct you to a very specific website. Each one of these patches is going to direct you to a very specific neurologic pathway. So the pathway that controls chronic pain is very different than the pathway that controls your ability to sleep or your anxiety or your mood or even your athletic ability. And so there are a variety of these patches. They're all considered FDA Class 1 medical devices, which means they're safe to use. You don't need any specific medical training to use them. And their function is more of a physical therapy as opposed to a medication. So you can use it regardless of the patient's age, what medicines they're on. There's really no contraindication to their use. And in my practice, I use them for the first one I was interested in actually was the pain one, because as a surgeon, I hurt people for a living. And so the first one that I was interested in was their Freedom Patch, which is for pain. But I found that my patients also benefit from being able to sleep when they're in the hospital, not having anxiety about having a surgery, increased balance, so maybe they're less likely to fall and hurt themselves. So I use a variety of these patches on a day-to-day basis with my own patients.
That sounds great. Marc, tell us a little bit about your use of the patch. How did you get involved with vibrohaptic technologies?
Yeah, thanks, Jeff. For me, it came in the lines of a phone call from a friend of mine who reached out. He's involved in sports and performance and does a lot of personal training and rehab out on the East Coast. And he reached out and said, hey, I've heard about this new patch. I want to give it a try. Is it a real thing? Does this actually work? What do you know about it? And to be honest, I didn't know a lot about it. I was like, okay, well, let me talk to some people smarter than me and see if we can connect the dots here. So I actually reached out to our department chair of physiology at University of Arizona, and he said, hey, actually, this is a field that is emerging. There's a lot of interest. There's a lot of research around sensory feedback, around haptics, around Braille, those same sort of neurologic connections that we utilize in those different areas. That's become an emerging science. And so with that, it really drove the needle to see, could this be something that would help our student athletes and our people who are trying to train and get stronger, faster, recover better?
Fascinating. Marc, it's interesting you mentioned the athletes. I'm sure they have some unmet needs in pain, wellness, sleep, but they probably try to limit their oral medication use. So how has the patch been helpful in your population?
Yeah, no, absolutely. For athletes, it's a big part of their whole mantra and approach is well-being, trying to do things in a way that's going to limit any outside, stresses on their bodies and things like we see with medications, where a lot of times medications have other side effects and systemic implications that we don't necessarily plan for or intend for. So as they're looking to find ways to be more readily available, ready to perform, they're looking for techniques and technologies that will bypass that medication route and interfere with the detail they pay in terms of attention to their food, how much they drink, how much they sleep, all those things. So they're really into that small percentage point gains, and this is something that doesn't interfere that balance, but can really give them some good results.
It seems like the body has this natural or innate ability to self-heal, and that we could amplify that. Anna, do you think this is kind of what we're doing with the patch technology like this?
Absolutely. As a surgeon, my primary objective is to improve a patient's ability to heal. And a lot of the things that are involved in the healing process is rest and avoidance of stress and an avoidance of pain if possible. The problem is a lot of the medicines that we give can cause confusion. They can interact with each other. If you've ever seen a patient take a pain medicine and a sleeping aid as well as an anxiety medicine, that is a recipe for disaster, particularly in the older patients. So there's definitely a need in the surgical world to have something non-medicated that can help the patient rest so that they can heal going forward. So.
Great. So let's discuss what is known about the mechanism of action for emerging therapies like wearables and haptic technology. The more I learn about this, the more fascinating I find it. If you recall, we have specialized receptors in the skin, like Ruffini corpuscles and Merkel cells, things we learned about in medical school. These are found in areas of the skin associated with high touch sensitivity, like in your fingertips. They're closely associated with the nerve endings, and they're believed to transform touch into electrical signals that are transmitted to the nervous system. And without trying to get too detailed, some of you may be familiar with the concept of piezoelectric currents. Well, we recently published a review on piezo ion channels that are located in the skin. I mentioned before the concept of converting touch or mechanical sensations into neural impulses. We believe it is these piezo channels in the skin that generates the action potential felt by haptics. But let's get back to patients. Can either of you offer any insights into the mechanism of action of the super patch?
Well, I can give you an example that I think the average person can easily understand about how these work. If you can think of an opportunity where perhaps you were at home and a little bug crawled across your hand and it kind of gave you the heebie-jeebies and your pulse went up and you maybe breathed deep, and you can think about that moment now and even still have a little bit of anxiety about it. You didn't see this bug, you only felt it, and it didn't have to go across the front of your hand. It could touch any part of your skin, yet your brain immediately identified what it was and then tapped into your physiology as a result of that. And so these patches and this technology are basically giving you a texture your brain recognizes, but instead of giving you the heebie-jeebies and a rapid pulse and anxiety, it actually reverses those things. So they're designed to put the parasympathetic and the sympathetic nervous systems in a balanced check so that you're not out of balance. We spend our lives in stress. We're way overstressed. This gives us tension. It gives us anxiety. It probably is the basis of most of our ailments, to be honest with you. When you can put the parasympathetic and sympathetic nervous system sort of in a balance, then all of a sudden a lot of these external symptoms, high blood pressure, anxiety, inability to sleep, inability to focus, will dissipate. And so that's sort of the purpose of using these patches and the mechanism through which it works.
Great explanation. So Mark, do you have any insights into the mechanism of action as well?
Yeah, I think another example, a little more basic, that we all see is in when we have injuries or musculoskeletal issues. A lot of times we'll wear something like a knee sleeve or a little soft neoprene ankle brace. Those types of proprioceptive responses help our body respond more quickly and reflexively to those areas when we feel that pressure, we feel that compression, or those signals that are stimulated. So similar to super patches, that's the concept where, talking to a lot of my athletes and patients, we kind of hearken to that and connect those dots that, hey, something similar is going on where that neuromuscular inhibition is being impacted by the patches, and hopefully, like we saw in our study, that it improves performance and helps things function better in the way they should.
We're going to talk more about that study in just a moment, but tell us about the subjects. Did they feel anything perceptible, or is it literally just an improvement in function or sleep or some other domain?
Yeah, specifically for the patch that we took a deep dive in, the Victory patch, it was a lot more around performance and that impact. And so when we put it on for the athletes, we wanted to see how well they responded in even a relatively short window of time. So they only wore it for a couple hours, but some of those, when they did the testing, felt like it was a bit easier. They felt that subjective sort of benefit from it, not just the numbers changing like we saw when we actually looked at the data.
That's great.
As a researcher and as an owner of a clinical research organization, I get a lot of questions surrounding do these things really work? Whether it be super patch or other devices and products that we study. As a researcher, I'm skeptic by nature, as are a lot of clinicians. How do you approach and what would you tell your peers about not knowing certain things of the MOA, of the super patch in this instance, and that are unexplainable? Obviously, there are things that we don't know in the area, especially in brain research. We're always finding out. What's your experience, and how do you share with them what you know and what you don't know?
Yeah, that can actually be a challenge because there's no medicine in it. What do you mean? That's the first thing people are looking for. And patients don't you can't feel other than you're wearing. Sometimes you forget you're wearing the Band-Aid. I've got 2 of these on right now. I don't feel them, but your demeanor does change if you're wearing one for stress. If you struggle a little bit balance, all of a sudden you have more balance. So that is a very subjective thing. When you get to the objectivity of it, it is helpful to use prior research in the medical literature, which corroborates the function without knowing that they're talking about superpatch. You know, whether it is a paper that says you can stimulate the sympathetic nervous system voluntarily to lower your immune system to fight autoimmune diseases. That is a paper that was written 3 or 4 years before this concept ever came up. Yet we know by using these patches you can tap into the autonomic nervous system to affect a physiologic change. So it's sometimes easier to use existing literature as a corroboration and then your clinical observation of what is occurring. There are a lot of medicines that we use that we don't know how they work, you know, and we just know that they do work. We use a lot of off-label mechanisms in ways that we don't really understand how they work. So I think when I approach the treatment of patients using something like this where research is still ongoing, we've got studies still going on, it is helpful to know, I know from a scientific standpoint that this is definitely possible. I know from a clinical observation, I'm seeing the effect of this occurring. And maybe I don't know exactly what's happening, but I can kind of put the pieces together that I believe it is happening in the way that was described by somebody else for a totally different issue.
Yeah, and not only obviously in your space and the areas that you concentrate on, but Jeff, we were speaking recently about what is known and not known in the analgesia field. I mean, you have any examples of that, how this potentially translates and compares to what we're seeing or not seeing or don't know about what we know about haptics?
Yeah, I think like Anna says, so many of the therapies we use, we don't really know the mechanism of action. I mean, ask a clinician how acetaminophen works, and it still really isn't known. Gabapentin we thought was a GABAergic drug, and it's a calcium channel modulator. So many examples of using a medicine or a therapy that has a clinical benefit without actually knowing the mechanism of action. And I think that's one of the challenges here. And like any emerging field, it's going to take time for clinicians to read the available data, for research organizations to develop the available data, to understand the technologies behind it. I mean, think about it. And Anna used a great example. Just a little tiny mosquito crawling on you could elicit such a response of your nervous system. Mm-hmm. Imagine the potential of haptics. And if it has something to do with these specialized channels that convert that touch or that haptic into a neural signal, yes, it only makes so much sense that there really could be potential of this therapy.
Yeah, it's funny, we were talking, right before we came on camera of even though a lot of the outcomes that we've seen already, and there's a lot that we haven't shown yet in terms of the outcomes because we are still evaluating data, but the outcomes that we have seen are P.001. And even though that's the best type of stat you can get, it doesn't work for everybody, But, you were mentioning about falls. Yes. If there's just a certain percentage, why don't you share with us that? Because that was obviously an interesting point that necessarily isn't, really internalized.
Yes. So in America alone, and this company is worldwide, but in America alone, 1 million people will fall in a clinical hospital setting, not just at home. We don't even know what the numbers are at home. 1 million people will fall, 100,000 of those people will have a significant injury, and 10,000 of those people will actually die as a result of this injury. So they're in the hospital for some other reason. They get a colon resection. They get up in the middle of the night, they're a little bit dizzy, they've been medicated with a pain medicine, with a sleep medicine, an anxiety medicine. They get confused, they fall. Now all of a sudden they have a broken hip or they have a head injury. From a financial standpoint, the hospital has to provide the cost of care for that fall. So there is a financial motivation from a hospital system. There is the physicians involved do not want to see any patient hurt for some unrelated reason. Like it would be the biggest nightmare in my life to operate on someone and know that they broke a hip in the hospital. It would be horrible. Right now, there's no ability to prevent that from happening. All we can do is label a patient high risk or low risk and put the bathroom closer to them and try not to tie them down too much so we're not impeding their progress. You can't proactively do something. So what is fascinating about this technology is for very little cost, you can improve someone's balance. So the question is improving that person's sway and their balance abilities, is that enough to clinically decrease their risk of fall? And even if everyone had improved balance, if only 10% of these people had lowered their risk of falls, you'd be saving 1,000 lives a year, 10,000 falls per year, right? And we do things right now in the world of surgery to prevent a 0.02% risk factor. So deep venous thrombosis, to prevent a deep venous thrombosis, we do blood thinners immediately after surgery, which I'm not a fan of, but we do. We put something called an SCD on a patient. This all is cost to prevent a complication that happens in 0.02%. And you're not preventing all of them by doing that. You're lowering that percentage by maybe 1 or 2 percentage points. So you can see how you can translate a 10% improvement in something into real numbers and have real impact on a person. And that doesn't include people in a nursing home or at home in and of itself. It can make a huge positive impact on society.
And going along those same lines, Mark, you were the principal investigator for a recent study that we administered, the Power Up study, which is currently in peer review for a major publication. And we have a couple major presentations about the data coming up. Talk a little bit about that study and really what the study was about, what you showed, what you measured, and really the potential downstream impact on the athletic performance and various areas that we're seeing.
Yeah, absolutely. And similar to, as we were discussing before, a little bit of that question of how does this work? What's the data behind it was a big driver for the study, and that's why we wanted to look at it and see objectively, could we identify a change from wearing the patch in a performance environment? What we did is we got 70 of our student athletes that were all Division I athletes across sports and entered them into a randomized, double-blinded crossover trial. So basically they did both the placebo patch and then the victory patch. And some started with one, others started with the other, just to make sure it wasn't a training issue or something like that where they just were a week later in their training and that much stronger or something like that. So we studied it about 7 to 10 days apart and looked at some basic metrics that we'll use across athletes throughout the year, which is basically knee extension, which is straightening out their leg against a force frame, knee flexion, where they pull back, and then what's called the counter movement jump, where they stand flat-footed, jump up in the air, and land on a force plate. So looking at that data, we were able to see that 2.001 in terms of the p-value, we were able to see anywhere between 5 and 8% improvement on the active patch compared to the placebo. And again, this is athletes compared against themselves and compared overall. And so it was exciting to see that type of data come through, because in sports medicine and athletics and Olympians and all that, it's fractions of a second. It's those small percentage points that make a huge difference. So extrapolating that out, you could see that this could become something very impactful. Another interesting part that we did find too was that there was a improvement in asymmetry from their right side to their left side. So we actually saw their non-dominant side get stronger, which was an unexpected finding, but makes sense. If we're improving the neuromuscular pathways, it's not that necessarily their one side's that much weaker than the other, but it's maybe firing more efficiently. And now all of a sudden, after wearing a patch for an hour, that signal is moving a little bit more effectively.
Great. And to that point, Anna, you've brought up previously about how the body is at a stasis and it comes back into stasis. Obviously, that goes to that point.
Right. Your baseline happiness is the stasis of things can go awry rather quickly as we age, or with habits, or with training. I mean, if we're talking about athletes, or someone like me, maybe used to be an athlete, then got injured, and now you milked along an injury, and that all of a sudden throws you completely out of balance. And your brain learns how to compensate for this learned change in your demeanor. And so now you're no longer in stasis. You're kind of out of whack, just so to speak, and then these devices can knock you down into whack. I don't know how to say that in a nice way, but can get you back into the stasis, and your brain recognizes it's like a touchstone of balance. It's like a solid surface in a dark room where all of a sudden you realize you're standing upright is sort of the reference point that this little texture is giving people. So it's kind of a fascinating way that the brain works.
Mm-hmm.
So Peter, understanding that the use of haptics to improve health is an emerging science. Superpatch has been behind a lot of the data that you could find regarding the health benefits of haptic technologies. Tell us a little bit about the clinical trials process that some of these studies have gone through and the publications that have come from it.
That's a great question, Jeff. From a clinical research organization, CRO standpoint, the studies we administer go through a rigorous process of development, as is standard in the industry and with other studies we conduct for big pharma. There are two types of studies that we have conducted in regards to these vibrotactile haptic patches. The first are called observational studies. These studies involve subjects who are asked specific questions about their experience after using the studied patch. The questions asked are from validated scales like the Brief Pain Inventory, the Perceived Stress Scale, and the Pittsburgh Sleep Quality Index, for instance, that have been used in thousands of other clinical studies. It also should be noted that the FDA has provided guidance on the validity of these observational studies and the value that they provide in terms of getting a better understanding of real-world evidence. Over the past year, we have also conducted clinical trials that, in addition to observing the patient's response and asking about their experience, we have also incorporated functional measurements, like having study subjects wear a Whoop device that records all aspects of a person's daily activity and sleep patterns. We've also taken measurements in Division I elite athletes that are standard performance measurements. With the incorporation of these functional measurements, we can compare what the subject is saying they are experiencing with actual objective measurements. Let me talk now a little bit about the protocol development process. We first identify a principal investigator, such as yourself. These are clinicians that are experts in the field and have experience in the study, in the area being studied. Dr. Toker, Dr. Saker, and you, as you know, have all been principal investigators for these vibrotactile trigger technology superpatch studies. With these clinicians who are selected, we then develop a protocol for comparing an active superpatch with a sham or placebo patch. The subjects in the study are randomized and blinded, meaning that they don't know which patch they will be receiving. The protocol then gets submitted after completion to an IRB, an institutional review board, which reviews the protocol and methodology to ensure that the study subjects are protected and understand any risks from the medical devices that are being studied. For the super patches that we have studied, they are non-invasive, have no ingredients, and are considered a Class 1 medical device, the category with the lowest risk. In all the studies we've done for super patch, we've never seen a severe adverse event, and any adverse events that have been reported were minimal. The outcomes we've seen include, in many cases, a p-value of 0.001, and if you remember from stats class, that means that there is a 1 in 1,000 chance that the results are by chance. The results from the studies have been presented at over 20 international scientific medical conferences after peer review from the scientific committees and been published in many scientific peer-reviewed journals that can be found on Medline, PubMed, and other literature reference libraries. We have many other studies in the works right now. All of them can be found on clinicaltrials.gov, and we look forward to conducting those and really seeing what the outcomes of those studies show. It's interesting, in thinking about, the experts we have here, Dr. Saker, Dr. Toker, and Dr. Gooden, as clinicians and physicians, you also have an expanded practice and interest. Dr. Gooden, you're an acupuncturist. Dr. Saker, you're a DO. And, Dr. Toker, obviously you are a very renowned colorectal surgeon, but also have an interest in wellness, nutrition, and run a non-narcotic practice. I'll start with you, Jeff. What does that mean? What are you looking for when you're looking at that holistic view of practice?
Peter, we insinuated this before. Self-healing, anything we could do to make patients better without the use of pharmacotherapy, without having to take a pill. We know that's where the side effect comes from. We see patients admitted with kidney failure from over-the-counter ibuprofen, acetaminophen liver toxicity. We see troubles with opioid therapies. I mean, you can't go a day without reading about narcotics and opioid abuse. So we really try to promote patient wellness, right? And for me, that's where my interest in acupuncture came. So in addition to recommending physical and occupational therapies and guided imagery and overall wellness, I incorporated acupuncture into my practice as just one more modality to kind of get patients over the hump of pain, anxiety, stress, sleep, all in promoting wellness.
Great. And where do you think Super Patch fits in all that?
Yeah, I mean, that's why I've been so intrigued by the Super Patch. And we've talked about, how does a clinician use a therapy that we don't understand? Well, we've been doing it for years. I mean, how does acupuncture work? It obviously something about breaching the skin barrier that alters signals that the body changes. There's a physiologic response. I put these tiny little needles in the skin and patients get dizzy or sweaty or they feel euphoric. I don't let some patients drive after acupuncture. There is some natural response to the body, oftentimes good, to manipulating at the skin or at the superficial levels. And I think that's how we'll figure out this patch is actually working.
Great. Anna?
Patients have come to sort of distrust the medical world. Unfortunately, we're living in an environment, in the last 5 years in particular, where they don't want to go straight for the drug answer. They want to do something on their own. They are probably more well-versed on medical side effects than a lot of doctors are. As allopathic physicians, we're accustomed to writing a prescription, and the patient is supposed to take that to a pharmacist and fill it. And for a long time, there was always this assumption that if it wasn't a prescription, it wasn't any good. And I have some patients make me write a prescription because they don't trust the over-the-counter. In the last 5 years, and this is kind of how I've developed as someone who talks a lot about nutrition and natural healing, the patient is more likely to want the over-the-counter thing or the herbal thing or what is the dietary situation. So the patients are definitely interested in a non-pharmacologic approach. From a surgeon's standpoint for the last 5 or 6 years, and this is driven by the FDA and the federal government and the opioid crisis, that me and many surgeons actually have gone to a narcotic-free environment where we try to restrict the use of a narcotic in the postoperative period, because it can take 3 to 5 days worth of that type of medicine to become addicted. And if you've known anybody with hemorrhoid surgery, right, that's more than 5 days worth of pain. So you can easily see how you could get someone addicted to a medication. Not to mention the fact that narcotics have all kinds of side effects other than their addiction, the nausea, the constipation, the sleeplessness. You can't sleep when you're on a narcotic, and it's also an inflammatory medication. So when you take all those things, those are all anti-healing properties of this pain medicine. And really, the patient only wants to have no pain or improve pain or tolerable pain. So if we can do that in a way that doesn't have the anti-healing properties, the patient is on board for that. Now, that does mean there's a lot of things you have to do. There's some herbal supplements that I will give patients and anti-inflammatories, but how I got introduced to this technology is definitely the Freedom Patch. Without any medicine on it, the patient can apply it when they need it. They can take it off if they don't need it, and it drastically reduces their perception of their pain. And they tell me that because they're not really reaching for the medicine. They're not asking for refills. They're not calling in misery, and they're happy that they have it done. So it's definitely worth pursuing from I'm a surgeon, I want my patient to heal better. And then the patients more and more are likely to accept that as the answer because they want to get well too, and they don't want to be addicted to their medicines.
Great. Mark?
Yeah. Well, in the osteopathic medical philosophy, really the understanding is that the body knows how to heal itself. And if we can restore structure, the body knows how to restore the function. And so be that through manipulation or musculoskeletal changes or improvements in how the body's aligned and how things are moving, or be medications or anything else that helps our body untangle some of the obstacles and some of the roadblocks that are happening from healthy function to kind of where we are currently. That's something that's exciting. And I think that's something that's worth evaluating and looking into. Super Patch and these concepts around vibrotactile technology really offer another tool or another opportunity to untangle that web and really allow the body to get back to what it's used to doing and what it knows how to improve issues and pathology, very succinctly.
Great. And you mentioned OTCs, right? Mm-hmm. Over-the-counters aren't all created equal. And, from a clinician point of view, they are used to, as you said, writing scripts, yes, because that is the better route to go. Mm-hmm. There's been a lot of studies. We've conducted a lot of studies on the vibro-haptic patches with positive results that they've shown. I don't know what the other patches that we're studying are going to show, but the ones that we have studied have shown positive results. Mm-hmm. What makes a study valid? What makes the data valid from a clinician point of view? And how is that then interpreted to patient care?
The first thing that I think most doctors are going to ask is when doctors are very skeptical, all right? So they'll ask to see the study. Where was it published? How many patients are in it? Was it properly powered? Is it placebo-controlled? And is it blinded? Those are the types of things you want to know. How many of those people dropped out of the study? What was the population? Were they even enough? Like, are we comparing apples to oranges? So physicians typically will read through at least some of that. When you get a study with that p-value less than 0.001, like we as doctors recognize that as there's really almost no other option. This can't be placebo, and it's not going to be the way we measure the data. That comes down to like something real just occurred. So they do like to see that. And, I've read studies in the past where that p-value is not very good, or the predictability, some of the predictabilities that are in a study are kind of off, or the way that it's written, it's sort of like, I don't know, was that really placebo-controlled? I mean, who knows? Then all of a sudden it gets kind of put to the side. So if you have a small group of people, maybe it's not placebo-controlled. People don't follow that as much. It is helpful to have numbers. So to do a subjective study where you're asking the patient to fill out questionnaires to get an answer, and I know those are validated studies, but a lot of doctors are like, are you talking the patient into that answer? Is peer pressure getting them to get to that answer? It's helpful when you see an actual measurement change, like what you were talking about with your study. There's a measurement there that you're finding. And so I think that's one of the things that physicians are looking for. Show me the measurement, not just the questionnaire.
Right. And Jeff, I would ask, again, for your opinion, obviously in the realm of FDA regulation and FDA approvals, there are a lot of studies out there and a lot of products that are on the market that are used in everyday practice. Aspirin, for one, obviously, that would never potentially get approved today.
Peter, I will say, without naming the drugs, I've been involved with a fair amount of clinical research and a fair amount of consulting on products that have gone to the FDA. And I think what we have to recognize as clinicians is that there's a difference between statistical significance, what we see in a clinical trial, and clinically meaningful or clinical significance, right? What does it mean to the patient? What kind of outcomes did they perceive? And the one place where I would commend the research organization with these studies on vibrohaptic technologies is not only did they do the scores of, okay, what was your pain score, what was your sleep score, but they asked patients their global impression. What did you think about the results of this product? And when you look at the patients that were in the treatment arms, somewhere 70, 80, 90% rated as good, very good, or excellent. And in the placebo arm, those numbers are 30 or 40 or 50%. So you see a separation in the difference of the subjects in the group of whether they got the active patch or the placebo patch. Again, these are blinded studies. Subjects like Mark, your athletes didn't know if they had a placebo patch or an active patch, and yet they rank consistently in your studies higher subjective ratings. And that's where you mentioned early on real-world evidence. I think that's what we need more of. And again, the fact that you're looking not only at the statistical significance, the p-values of, what were their ratings on a questionnaire? What did the subjects say? What did the patients say about the outcomes from these trials? And overall, it's been positive, which is attractive to clinicians like us when we look at data. Peter, we've mentioned a number of times today that the science regarding vibrohaptic technologies for improving health is emerging science. Can you tell us about some of the publications that have come out of your research? Any other data that might be available?
Sure. So as we heard a few minutes ago from Marc, as the principal investigator of the Power Up study, he shared the results of those outcomes in the Division I athletes. We've done and published other studies, one being the sleep patch, which is the REM patch that we studied for sleep improvement in subjects, and that was the RESTORE trial, for instance. We showed that sleep showed statistically significant decreases in time to fall asleep, an increase in number of hours of sleep, level of sleep, and reduction in the global PSQI score and ISI scores for the active treatment group as compared to placebo. After 14 days, over 33% of active group subjects reported that they reduced the amount of over-the-counter or prescription medication that they were using for sleep issues. And all three key outcomes in the active patch group, the global PSQI score, the ISI total score, and minutes to fall asleep, followed a similarly strong downward and statistically significant trajectory from baseline to that 2-week period of time at day 14 with no significant adverse events. In the Strava stress study, which looked at the Peace Patch, research subjects' mental health status improved significantly, p.001, and there was a positive outcome and statistically significant percentage increase, p.001, in health perception over the 14 days that they were in the study. And Jeff, you were the principal investigator of our Harmony study looking at the pain patch, the freedom patch. Why don't you share a little bit of data and outcomes from that study?
Sure. So, you mentioned a little bit before when you designed these trials, the questionnaires that we use to ask patients about pain, about function, about sleep, about their overall perception of the benefits of the patch. So in the Harmony study, it was a controlled study. Patients used a haptic vibrotactile trigger patch, and the patients in the active group saw a 47% reduction in pain severity and a 50% decrease in pain interference. That's a measure of function. Patients were 50% more functional when they had this active patch, which was similar to your study, a 14-day trial. When we asked patients, 82% of them reported reduced use of oral pain medications, another really important point that we talked about as a panel. We also asked them questions about quality of life measures like mood, sleep, and general activity. All of those significantly improved in this particular trial.
We have a lot of other ongoing studies, including those on balance, that's the PROTECT study, and Optima, which we're actually looking at the resting metabolic rate for metabolic outcomes and see if there's a difference in there between an active patch group versus a placebo sham group as well.
That's great. Peter, I was really intrigued by Marc's athletic performance study. So you told us before that your athletes didn't know whether they had on an active patch or a placebo patch, and we saw that there was improvement in strength. Any other domains or anything else you could tell us about the study?
Yeah, one of the interesting things that we found that I think is a pathway for some further research and understanding was that we found that athletes that wore the active victory patch for more than an hour had an interval increase in that positive effect from the patch. So it really brings to the forefront the question of, is there a dose effect? Is there something of, hey, wearing it for a full 24 hours or maybe even day over day, is that something where we'll see exponential changes and that growth and the difference that you would have compared to not wearing a patch?
Wear times is actually a great thing that needs to be studied. Anna, tell us a little bit about your practice. How long do patients actually wear the patch?
In the protocol that I've set for my surgical patients is for 2 weeks prior to an operation is when I want to sort of get them, since all of your studies are 2 weeks long, I'm going to use that clinically in my own patients, where for 2 weeks I have them wear a pain patch, a peace patch. At nighttime, they'll use this REM patch to help sleep, and then they wear 24 hours a day one of those balance patches. And they do that for 2 weeks beforehand. They bring them to the hospital while they're recovering, and then for another 2 weeks afterwards. And I feel like, in my experience, if you can get a patient in their best, most relaxed state, they're more likely to respond well to the operation because they're not stressed. Someone who is confident in themselves, They're confident they're not going to have pain. They're going to be able to sleep. These people all of a sudden are much less stressed about the operation. So now their time in the hospital becomes much shorter. You're talking about a day and a half in the hospital after a colon resection, sometimes less than that, simply because the patient feels good. They know they're not uneasy on their feet, they know they're not overdrugged, and they know they don't have any pain. So it's extremely effective if you can start them early. It gives them a confidence. They can, while they cannot feel the substance of these patches, their demeanor, they know that it's helping them in some way or another. As you said, like the athletes almost feel like, it's not like wearing a cape, but you kind of get that there's some form of balance that occurs that is being struck in these patients that gives them confidence. And that allows them to heal much quicker and get back to life much quicker.
You know, in the surgical and the anesthesia world, we have this concept of prehabilitation.
Yep.
Right? Getting yourself in
big on that.
optimal shape.
Yeah.
Right? Getting yourself in optimal shape for your surgical procedure to enhance your recovery.
Yes.
And then when you look at the anesthesia literature going back at least 20 years, we talk about this concept of preemptive analgesia.
Yes.
Can we alter the neuromatrix? Can we alter the body to be prepared for this insult? Can we stop this excitatory cascade of nerve impulses and chemical release simply by blunting the response before the insult?
It's just like when I operate on someone, I always give the local at the beginning of the case before I make my incision, right? Just based on that. Yeah. The patient's asleep, they're not going to feel my incision, but their chemistry feels the incision. You always give that local first. And so I feel like from a physiology standpoint, we do something called the enhanced recovery after surgery. I know you're probably part of that in your hospital. Most surgeons do engage in this type of behavior where we prepare the patient from a nutritional standpoint, from a relaxation standpoint. I get home health out to their house to make sure there's no impediments at the home. And so these patches have just become part of that protocol. Just like a high protein, low inflammatory diet, just like me giving local before there's an incision, all of that is part of this enhanced recovery protocol.
Great, and you're looking at this as clinicians, as not only as you're looking at that proper patient selection for this, but you're looking at this super patch as a complementary medicine as part of a multimodal
yes.
Delivery of patient care. And again, as you're dealing with college athletes or all types of and ages of patients yes. As well, are there any concerns that you may have about this that physicians, again, who are skeptics by nature,
yes.
right, have in terms of should I be concerned about X, Y, or Z?
Well, I'll go first, Peter. You know, if you think about an agency like the FDA, they're concerned about efficacy, but they're even more concerned about safety, right? So the therapy has to be safe. And I think you've shown from a number of studies with hundreds and hundreds of patients at this point that the worst adverse effect that you've seen is probably an adverse reaction to the adhesive, to the stickiness on the patch. So I think we've seen, at this point, we're at least assured that there's no major safety issues. From a science standpoint, we're probably not going to see changes in electromyography, actual large motor fibers, but we may see changes in EEG. There may be some ways to measure these piezoelectric channels, right? So as a scientist, I want to know, hey, how is this thing working and can I justify the clinical results that we're finding out of these trials?
Anna?
Yeah, I think clinically, we use a lot of things in medicine, again, because they're safe, as an adjunct to the other stuff. And patients are actually highly motivated to do that. Just like you would give someone crutches if they twisted an ankle, this is simply a supportive measure. The crutches are not going to fix your twisted ankle. They're simply supporting you while your body naturally heals. And honestly, the FDA sees these patches in the same category as an ACE wrap or crutches. This is just an externally applied physical therapy device. It is not designed to actually fix you. It's simply designed to support you while your body naturally does kind of what your body naturally does. And patients are on board with that. And physicians, if they know that it is safe, and so that's the first thing to tell them, there's no contraindication to this. It doesn't matter if they're on blood thinners or how many different medications they're on, what their age is, or any of those things. So it makes it so much easier to add it And it makes my life a lot less stressful if I don't have to now add a dangerous medication to the 85-year-old lady, right? It makes me personally feel more comfortable that I don't have to give something really overpowerful to someone who maybe can't handle it.
Great, and Marc, as a athletic medical director, not only at the collegiate level, but at the professional level as well, not only that enhancement and improvement of potential athletic performance, but as a primary care physician as well, treating the patients as medical director at University of Arizona too. Your thoughts?
Yeah, I think similarly, really safety, what are the risks of any new treatment or approach that we're taking with patients or athletes? The third part, though, that gets interesting, I think sometimes is an obstacle is, does it make sense sort of academically? Like, how is this modality or this supplement or this treatment going to work to help our patients or our athletes get to the goals that they're looking for? I'm fortunate in the athletic space that, people are a little bit more open-minded to, hey, how do we get to that next step or get that advantage and really beyond the bleeding edge of the spear? So there's a lot of openness to try new things. But as part of my responsibility is making sure we're doing it safely and we're not just trying just whatever showed up on a website somewhere and that they got delivered to their home. Right. How do we really look at an effective concept in terms of treatment? And I think to your question specifically about some people's hesitation around new things is developing that understanding of how is it getting us from A to B. And I think that's been the important part of all of this research, is to help fill that gap so that now we have an understanding that, hey, this is the mechanism we're leaning on and this is how we're explaining those results and counterbalancing the risks or lack thereof in something simple like the super patches.
Well, this discussion has been amazing. I'd like to thank our esteemed panel for joining me today for this session on emerging therapies in haptic wearable technology and our discussion on the potential benefits of the super patch. Vibrohaptic patches represent a promising frontier in wearable health. Current studies support their capacity to reduce pain, improve sleep, aid rehabilitation, and enhance sensory experiences. Super patch has been a pioneer in this space. Just think about the possibilities for wearables that improve health, from apparel to footwear, and even steering wheels and hospital beds. While more large-scale trials are needed, the data so far points to powerful, non-pharmacological benefits rooted in solid science. For those interested, super patches for a variety of indications are currently available online. Stay tuned for more advances as this technology evolves. Thank you.